Our four speakers are Dr. Marcus Plesha. He is the Chief Medical Officer of the Association of State and Territorial Health Officials. And during COVID-19, he's been AASHTO's principal spokesperson and primary liaison to the CDC. Dr. Plesha, if you could give everybody a wave so they can identify you there.
Be on the call. Yeah, thanks.
Okay. Claire Hannon is Executive Director of the Association of Immunization Managers, a nonprofit membership association that represents immunization programs in public health agencies. States, as well as some big cities, have their own immunization managers and immunization programs. Claire, if you could give us a wave.
Hey, everybody. Thank you.
And Dr. Narev Shah is Director of the Maine Center for Disease Control and Prevention. Previously, he was Director of the Illinois Department of Public Health. Dr. Narev Shah.
Hey, everyone.
And we do not have Dr. Umair Shah yet, I don't believe. So as soon as he comes on, I'll give a brief shout out to him. But Dr. Umair Shah is Secretary of Health in the Washington State Department of Health. And for our Texans in the room, he previously was Executive Director and Local Health Authority for Harris County, Texas. And so he just went from Texas to Washington State a few months ago. So if you have Texas specific questions, you can have at him there. Let me just, before I even launch into anything here, do any of you have a question we want to get started, or do you want me to start? If somebody has a question left over, we'll go to Laura. I'll just let this roll as Q&A, unless if you don't have more questions, I'll ask some questions. So Laura, so you can get started.
Hi, doctors. I'm Laura Bischoff. I'm a reporter for the Dayton Daily News. I work in our Columbus office in Columbus, Ohio. Could you describe, and I'm not sure who among the three of you is best suited to answer this, but the main pinch points in the vaccine rollout nationwide and how those can be solved?
Yeah, I can go ahead and start. And then certainly Claire and Marcus have immense experience with this too. But one prefatory note, I unfortunately will have to hop off on the earlier side, 12:40 or so. We have a press conference with MyGov at 1, making some big eligibility announcements today. But so, if I think about vaccination from the patient journey side, it immediately eliminates several challenges. The first among them is scheduling and registration. That is a perennial challenge. I'm just looking in the chat. There are some discussion there about why that is and some of the legacy reasons for that. But as a result of not having a national platform around scheduling, states have had to go it alone. Sometimes that's resulted in patchwork registration problems. So that's certainly something. And as the demand subsides just a little bit, then those scheduling problems will probably come to the fore. The second is logistics. So right now, what you in effect have are states and state health departments and state governments and some cities operating as very highly sophisticated pharmaceutical distributors. And we're getting the job done. I'm thrilled with the work we're doing, but it is a skill set that we've had to learn on top of the skill sets of ramping up testing tenfold, hiring hundreds, thousands of new staff around. So that's just two. This is MyGov's press secretary. So excuse me, I apologize, everyone, but I'll hand it over to Mark.
Okay, Dr. Plesha.
Sure, I'll jump in a little bit where Narev, I think, was leaving off. Keep in mind that we have a lot of experience in this country with providing vaccinations to the general public because we do that every year with the influenza vaccine. But we don't really run that out of the public health departments, and public health departments are very closely engaged with that. But 60% of people who get a flu shot get it through a medical care system. Another 20% get it through a pharmacy. So this is a little different, and I think it needs to be different because there needed to be kind of centralized authority, kind of organizing all of this and trying to prioritize it. And I think that's what Narev or Dr. Shah was getting at with his comments. One thing I wanted to add is, just keep in mind, this is all against a backdrop of a situation where demand right now is far out exceeding supply. And that's, when you look at the lines, when you look at the frustration, when you look at some of the systems get overwhelmed, I mean, that's really what's at play there. Probably that's a good problem to have. I'm glad that we have such a robust interest from the public. But that will get better. And I think one of the main messages we've been really urging is just for people to be patient. We will start to see a greater supply of the vaccine soon, I think, and at least in the next month. And at that point, then some of this immediate issue may start to really improve.
And Marcus, this is Umair Shah, the other
hey,
Shah. So, hey, I'm so glad to join Nirav and you on this. And apologies, I was running late. I just wanted to make one other quick comment to take the thread from Nirav and Marcus, you to me, which is that as I made this transition from Texas to Washington, and I won't go into that, but I do want to make this comment, which is that supply demand right now, there are 10 people for every 10 people ready to jump into the seat for every vaccine we have available. Supply will increase in time, and when that happens, we are going to have this real issue of vaccine hesitancy that's going to potentially rear its ugly head, and that will be sooner than later. It right now, in my mind, is being masked by the fact that we have such limited supply. And so we would really look to all of you to help us with getting the word out over time with credible information, because the distrust, especially in many communities that have been disproportionately impacted by this very pandemic, is a significant concern for all of us in public health. And we do want to make sure that we are thinking ahead, not just to the immediate supply demand equation, but ahead when we really do have issues and challenges related to vaccine hesitancy.
Okay, so welcome, Dr. Umair Shah. This is Chris Adams. Good to have you here. Really appreciate that. So we do have several questions coming in. We do have one scheduling consideration. Claire Hammond she's only be able to be with us for roughly the first half of this. Claire is with the Association of Immunization Managers, and so if you have questions directed at her, we'll try to get to those early. But Claire, I was hoping you could just give the fellows a sense of what the Association of Immunization Managers does, and what kind of, who the people are in each of their states who are members of your association.
Sure, and both Dr. Shah's are up at the state health official level, and they will have an immunization program director within their agency, and that immunization program director is the member of our association of AIM. So 50 states, 8 territories or federated states, and then 6 large cities receive funding from CDC to conduct immunization programs year round to manage the Vaccines for Children program. And so they've played a key role in developing plans for the COVID vaccine campaign, and then of course with implementation, and they are within the state health agencies. And so Dr. Pleshet Asto is that larger association. We have 2 health officers here, and then I would be representing the immunization programs. We're all, working together in the state public health agency.
Okay, so thanks for that introduction. We'll start getting back to the fellow questions. Laura Schulte first.
Hi, yeah, so I just have a question relating to, who is distributing or, giving out vaccines. So yesterday we got word that the university here in Wisconsin, I work for the Milwaukee Journal Sentinel, the University of Wisconsin canceled 4,000 vaccine appointments, and most of the people's appointments that they had canceled had been previously canceled before, delaying them again. And the advice that was given out was to maybe try registering with Walgreens to get an appointment for a vaccine, because the UW isn't getting the doses that they ask for. I'm wondering how that works. Why would Walgreens have more access than the university would?
Well, I could just start out with that, and just start out by saying that the vaccine allocations that are coming from the federal government are going through several different channels. The largest one is going to each state, but there's also a federal retail pharmacy program where the federal government is allocating some vaccine directly to the retail pharmacy chains. And, those retail pharmacy chains are working closely with the states, but they're putting their doses that they're receiving into locations within the state. So sometimes, there may be vaccine at Walgreens when there isn't vaccine that's coming through the state allocation program. That state allocation has been, farmed out to all of the providers within the system. I'm not sure what's caused those cancellations, but we did just have a whole week where vaccine was not delivered because of weather. And so that's kind of thrown things off, the deliveries, even to places like Wisconsin that know how to handle the cold, right? The vaccine's coming from someplace where it couldn't be shipped out. So that's put several states on the catch up. And the vaccine is getting back to delivery normalcy this week, but that has impacted a lot of cancellations. And I think, but you've hit on one of the key challenges that states have, which is that, vaccine being spread across multiple locations, and each of these locations or health systems or pharmacies have their own scheduling systems. And so trying to coordinate that and trying to have the consumer be able to find vaccine is a major challenge. So that's why it's, at several different places for you to check.
Okay. So we'll go to Lisa.
Hi, Lisa Kaczynski here from the Boston Herald in Massachusetts. My question sort of actually goes off that a little bit. Our state was lagging at first in doses administered, the actual shots in arms, and we've been catching up very quickly because our state has shifted almost everything towards mass vaccination sites, cutting doses to hospitals, new first doses to hospitals, to local boards of health, to now universities. Just today, we're getting word about that in favor of these mass vaccination sites, which make our numbers look better. But I'm curious if you think that is the best way to do it. Should these mass vaccination sites be what's being prioritized? Would it be better to be working with the more kind of local community types of distributors?
I can go ahead and
Sure.
start on that really quickly. I want to be clear so as not to speak in definitives or superlatives. You sort of asked two questions simultaneously. It was Lisa, right? Yeah. On one hand, you sort of said, is that the only way it should be done? And then you also suggested or asked whether they should be prioritized. Is it the only way? No. In our state, in Maine, we have at least 5 channels of vaccination that we are utilizing, but we are prioritizing the large-scale public-facing vaccination sites. To put that in starker perspective, if I magically got 100 more doses of vaccine coming into the state, on top of the 40 or 50,000 we're getting every week, you gave me a marginal 100 doses and asked me where I would put them, the lion's share of those would go to the large throughput sites. The reason is that in a pandemic, literally every day matters. And if I can vaccinate somebody on day one, a large number of people, 6,000, 8,000 people per site on day one versus waiting for day 6 or 7 when it might happen in a smaller throughput site, that is 6 or 7 days of immunity that I've conferred, and every single day matters. That is not to say that those sites should be to the exclusion of others, but the other thing to bear in mind is that even if we maximized all of the non-large scale channels, doctors' offices, pharmacies, things of that nature, we would not be able to tap into the throughput that we would need to vaccinate people in any amount of time.
If I could just add in, I think if there were a third state health officer I was going to suggest adding to this fabulous lineup of the two Dr. Shaws, it would be Monica Burrell, the state health officer in Massachusetts. And I just want to kind of give a little perspective here. I think that Massachusetts has tried to be very, very thoughtful about the equity issues around vaccine administration. And, I think all of the states have had their hands forced a little bit on how they come at how they approach vaccination, because there's just been such a huge public demand and so much pressure to vaccinate as quickly as possible. And the downside of that is you're going to lose equity when you do that. I mean, the more this becomes a first come, first serve system, the more it becomes inequitable. And I think that Massachusetts was really, really trying to kind of stay with that approach. But, the downside of that is it made the numbers look bad and there was a lot of pressure. So, I mean, I think it's an important point I hope would come out for all of you as journalists is, that there's a real balance here. And, I think we've landed at this place where we are just trying to handle the fact that such limited supply, but we've got to find a way to shift back to looking at doing this in a fair way.
That was just to follow up on that the equity issue is the main reason. Like, we had a 6-hour legislative oversight hearing yesterday. Monica was one of the people who testified at it. A lot of people in Massachusetts, lawmakers, public health officials, are angry right now because they think the prioritization of mass vaccination sites is at the expense of that equity issue. So the state, that's interesting actually to hear you say that you think Massachusetts is doing it well, because on the ground, a lot of people say that Massachusetts is not. So just wanted to follow up with that. Thank you.
Yeah, Lisa, this is Umair Shah from Washington. Actually, I'm in Texas right now. Last week was a pretty rough week for us in Texas. I just flew back from Washington late last night. What I would say is that one thing that we've been doing in Washington is we put together two arms of sort of addressing this very issue. I do think it's a false narrative or false dichotomy that it's either effectiveness throughput numbers or it's equity. I actually think you can do both. We must and we have to do both. What we did is we put together something called the VAC Center, VA, capital V, capital A, C, C, S, VACCS, VAC Center. And it's really designed for public-private partnership, and Microsoft, Starbucks, and Amazon, and Costco and others are coming into the table and really helping Department of Health to really everything from throughput and process flow, communications, what's happening on our website, all those even call center, very, very much public-private partnership. But on the other hand, we have something called the VICS, the Vaccine Implementation Collaborative, or Collaboratives, VICS, VICS, and it's designed for equity, feedback, dialogue, stakeholder input. And really, in my mind, it's complementary, that we have to really work on effectiveness and throughput, including in high output clinics or mass vac sites or whatever we're doing, but we can also use an equity lens in the process. And unless we're having both of these together, we're going to continue to have this almost demarcation that really isn't helpful. So even in a mass vaccination site, you can, for example, reserve some of those appointments for certain community members or through certain types of groups. For example, you can say to some of your disproportionately impacted communities, those CBOs, and you can say, look, we're going to give some proportion of those appointments that are going to be set out X% that it's for this, or another group that's for those who are phone calls, not necessarily online, because we know that also creates potential inequity. So I think it's being intentional about how you do that. But to your comment about Massachusetts, I will say the one thing that all of us have learned in public health is that this is a crisis. This is a pandemic. We have underinvested in public health over the decades. And for us now in the middle of a pandemic to expect perfection is just not reality. And so we have to recognize that everything we do, these are processes that can be improved, and there are things that we are having to do in real time to pivot. But at the same time, we also have to recognize that we are in a race against time. And so we're trying to do everything at the same time, which is making it very challenging. But that's what public health has been tasked with. Our department has been, and same I'm sure for Nirav and Marcus and others, is our department has been up for 400 days plus for response at Department of Health. And it was very similar at Harris County. Our first health alert was January 9th. So, 400 days of response of days, nights, weekends, holidays is just a testament to public health across the globe that has really been doing this and yet has not been recognized and oftentimes been vilified for the very things that we're trying to do to address a pandemic that we haven't seen in recent memory.
Thank you.
All right. So next, Lauren G.
Hi, yes, my name's Lauren Gibbons. I'm a reporter with MLive in Michigan. We have several newspapers throughout the state. And my question pertains to the federal funding. One of the issues I've been following is how Michigan still hasn't allocated the federal vaccination funding from the most recent round of COVID-19 funds. And there's been a lot of heartburn over whether to release all of the funding at once for vaccination rollout. And some of the Republican lawmakers have suggested withholding certain funds or only allocating funds quarterly or month by month, essentially. And one, I'm wondering if states can do that. Is there like a time limit on when this vaccination funding has to be spent? And two, what are the implications of delaying this federal money for vaccinations or potentially only releasing it, incrementally?
So
I can. Oh, go ahead, Claire. Please.
I just wanted to ask a question. Is it that your legislature, so the federal funds that are coming in to support your COVID vaccine program have to go through your legislature and get approved? Is that?
Yes, that's
Okay.
essentially the delay. It hasn't been allocated yet by the legislature.
Okay. Well, Dr. Shaw, you go ahead.
Well, Lauren, there's not a single answer here. This is a perennial problem or a issue that comes up. It came up a couple of years ago with respect to opioid-related funding that was coming into states. The rate and velocity at which states spend money balances a bunch of factors. One of which is there more in the offing? And if there is, then that changes one set of that changes the approach. And if there's not, or we don't think politically there is more, then we have an impetus to be a bit more conservative in how we roll out the funding. I can't speak again specifically for Michigan, but I know that getting funding out the door is also very, very difficult. And even in a pandemic where so many of the rules around contracting, procurement, and grant making have been lifted in many states, it is still exceedingly challenging. And you also don't want to spend if you think that funds may not be available for, say, a surge that might be coming in the near future. If you spend prematurely and you need to amp up your genomic sequencing, but you've already obligated all of your funds, that's a blunder as well. So there is no ideal. It's a series of trade-offs and value judgments.
Yeah, and the funding that's coming for, this COVID vaccine response has a 2-year window of spending, but we view it as a down payment. We don't think that it's enough to support everything that needs to be done. So, it's difficult to make a judgment for Michigan, but I would just say that, states need that funding and they need to spend it, and we're advocating for more to come. So hopefully the legislature wouldn't hold it back.
All right, next question, Mayan.
Hi, I'm Mayan Schechter. I'm a reporter with the state newspaper in Columbia, South Carolina. South Carolina, probably no different than many other states, is trying to figure out how to do its next phase of COVID vaccine disbursement. There's been a lot of conversations about obviously teachers, like I know other states have talked about. And then there's been just a huge kind of debate and dialogue about rural versus urban, how many of the vaccines should be dispersed to hospitals or these major vaccine sites in urban areas versus sending them out to the middle of nowhere where obviously the population is much smaller. I was wondering if you have any advice, because one of the issues that we've been trying to figure out is how to kind of compare our vaccination efforts compared to other states. And I'm wondering if you have, and we've just obviously been getting nowhere, like which state works better? Is our system perfect or is it terrible? And so anyway, I'm wondering if you have any advice about how to look at that, or if the advice is just stop comparing yourselves to other states and just focus on your own.
Well, it is very difficult to compare. And I think that sometimes rankings come out using the CDC COVID tracker. And, that's really put a lot of pressure on efficiency, and it's not necessarily the best marker. So every state is structured differently with public health. They have different data systems. They have different, urban versus rural, different partners, and I think both Dr. Shaws can comment on what leads to success, but it's definitely around collaboration and getting the community together. We see different strategies successfully working because of that, and other strategies or the same strategies not working in areas where they might not have great collaboration or great partnership. So it's difficult to compare. I think that getting doses into arms is the important thing, and it's happening, making sure that you're getting it out to the rural areas. Those things I think are working across the board.
Yeah. Claire's right. I mean, sorry, Amir, I'll just, it is really tempting to just boil everything down to a number, a rate, for example, the rate of velocity of shots in arms, things of that nature. But I think by focusing only on how quickly people are getting vaccinated, there's a tendency to glide over the question of who is getting vaccinated. So to the question itself, we are in a very rural state with a very low population density. We've taken deliberate steps to have high throughput centers, but also work with federally qualified health centers, home-based visiting nurses to get vaccine out to them, literally to the ends of dirt roads. So I don't think the two are in conflict. We've done so on a county by county basis, roughly by allocating to counties as a function of their population. So there's some degree of equity behind that. We're also using metrics like what percentage of people 70 and older in each of our counties have been actually vaccinated, and using allocation strategies so we can true that up. I don't think the two are in conflict, but distilling everything down to one or two numbers without getting a sense of the composition of who's being vaccinated, that's, and different states may make different choices in that regard.
Yeah, I just adding to what Nirav said, I would completely agree. It's, it is tempting, and you have so many different, you have New York Times, and you've got CDC, and you get the Becker's report, and you got so many different ways of looking at it. And which is it? Is it per capita, or is it the numbers that you vaccinated? I mean, we all know that there are so many different ways to slice this. I would caution us just to what both Claire and Rob just said. I would caution us not to try to make this like the NCAA top 25 and start to go, it's number 5 and number 8, or no, is number 5 markedly better than number 15, because it's just not that simple. And every state and every locality has a different narrative, and I think it's important to really dive into those narratives. I will tell you, in Texas just now, as I was in Washington this week, Texas FEMA was launching 3 sites, these large mass vac sites in Houston and in the DFW area. And so here I am in Washington thinking, gosh, you've got lots of increases that are going to happen with Texas, which is rightfully so. And here we are in Washington also wanting to do a very similar thing. So now you start to get that kind of piece that gets into the mix. So I think the other thing that I would just put out there, which is really critical, is that we are all needing to support the activities and the messaging. And when we start to say this is not working well, we sometimes undermine the confidence of the actual work that's happening. And none of it is going to be ideal. But I do think what it leads us to are questions that then very much undermine systems that are really trying to do exactly across the country, which is to vaccinate as many people as possible. And to do that equitably and to do that with nuances, I think is where the real challenge is from a reporting standpoint, because it is easy to go with the numbers, but it's harder to actually give the narrative of the nuances of what's happening on the ground.
I have to leave, but I just wanted to say, thank you to all of you for covering this, and just to encourage you to cover it with stories about who's getting vaccinated and, the things that we are succeeding. I think what Dr. Shaw just said is so critical to keep the confidence in the vaccine. We are going to get to that point where, we need to really have that trust in the vaccine to make sure it's getting into arms. So thank you for everything you're doing. And, the stories that you tell are really the ones that make a difference.
All right. Thank you very much, Claire, for your time. Next question goes to Ethan.
Hello, I'm Ethan DeWitt, a reporter at the Concord Monitor in New Hampshire. I had a question for Dr. Shah, Nirav Shah. Sort of a regional question. We've talked a little bit about teachers. I kind of wanted to compare New Hampshire's to Maine's approach right now. It seems like Maine is not prioritizing teachers, and I just wanted to allow you to kind of walk through that. What does the science say about whether teachers need to be prioritized?
Sure. Ethan, as I flagged a couple of minutes ago, Governor Mills and I are actually going to be convening in 30 minutes to talk about our next phases. So I can't give you that before 1 p.m. But what I can say is that right now, and since the beginning, Governor Mills is focused on risk of death as her North Star in terms of figuring out who gets vaccinated next. And I can't say much more until 1 o'clock, to be totally straight with you.
Okay.
Sorry.
All right.
Can I jump in?
I was hoping you'd forget about that.
Can I jump in since Nirav can't fully go that route because he's got something in 30 minutes? So let me give a different regional perspective on the Pacific Northwest side. What I would say is we absolutely recognize the importance of teachers and educators, and we know how important education is to our society, to our kids. Absolutely. I'm a parent, my wife, three kids, 11-year-old, 6-year-old, 4-year-old. We are constantly talking about their education, their development, and our concerns about, everything that goes into their lives right now. What I would say is that when the CDC put out its guidance, this past week, it did point that vaccinations were not a prerequisite for reopening safely. But what I do want to focus on, the way I've been championing this in Washington, is that there are two prerequisites, though, that we do need to focus on. One is community transmission, to make sure that is coming down or at a low enough acceptable number or rate. And number two is that those schools or school districts or schools specifically are putting in place the absolute right preventive protocols, and that they're implementing those successfully. Those are two prerequisites. So while everyone is focusing on this third question, those two are really critical in my mind, because if we as adults, and we've said this throughout the pandemic, if we as adults can do everything we can get our schools open sooner, safely, in person. But it's up to us as adults. It's not up to our 5-year-olds to do that. It's up to us to wear our masks and do all those other kinds of things. And number two is that the schools and the school ecosystem have an incredible job and challenge, but also responsibility to have those protocols in place that are going to allow those kids and those educators and the ecosystem within the school to be safe places for individuals to be together. We have 200,000 kids in the state of Washington that have gone back in person, and we have very few clusters, and the clusters are very small. And we have not had significant adverse outcomes from those 200,000 kids going back to school. And that has nothing to do with vaccinations. That is just to date. So we have to really be thinking about this in a very, very global way of how important education is, and especially in-person education is to our kids. But at the same time, if I have one group because of occupation who's really wanting to get vaccinated today, and I'm going to move a 75-year-old individual who I know is at risk for adverse outcome or death, that is the goal that we in Washington have taken, is our stance is to protect that 75-year-old because of that concern for the significant outcomes that all of us have been concerned about throughout this pandemic. So Ethan, I hope that helps. Sorry, Nirav, I just wanted to add that in because it kind of doesn't give you what's going on in now 27 minutes, but it gives that perspective on what we're trying to achieve across states across the country.
All right, thanks very much, Dr. Shah. So we're doing pretty good on time. We're going to go to Casey next because she has a follow-up question on the teacher issue, and then we're going to go to Sam, Jill, Stacy, Stephen Fowler, and Gabriella. So Casey?
Yeah, hi, I'm Casey with the AP in Indiana. I do have a follow-up question on teachers. I've been kind of keeping track across the country what different states and school districts are doing in terms of getting teachers vaccinated. And part of what I'm looking at is if or how either states or local school districts are actually trying to keep track of who or how many teachers have actually gotten the vaccine. And it seems like a lot are not specifically keeping track or even asking their teachers if they've been vaccinated, which is interesting, as some districts are weighing whether or not to go back, like you had been talking about. But I'm curious what the thoughts might be on if there should be specific tracking of teachers within districts who are being vaccinated, or what some of the complications might be with that. I know I'm hearing some concerns about HIPAA and privacy laws, but it seems like that might be helpful data to have when you're trying to determine if schools should go back in person, or if enough teachers in a district have gotten vaccinated. I just wanted some thoughts on that.
Yeah, I can start there. We similarly do not track by profession, generally speaking, who's been vaccinated. It's more just by age, race, so on and so forth. So we haven't been tracking by ethnicity. But you raise an interesting perspective, which is for groups that we consider to be high priority, how will we know that we have achieved whatever goal that we have for them, whether it's 80%, 100%? As you noted, having an employer track whether employees have been vaccinated does raise certain and various privacy concerns. Teachers may not want their employer to know, so on and so forth. And so I don't know that there's an exquisitely ready off-the-shelf solution for that. I think the way that we've thought about it is for groups of concern for us, we've tried to work with employers to get sort of a roster so that we can make sure that when they show up for vaccination, there's eligibility criteria, that we know their name and so on and so forth, rather than trying to track everything on the back end.
And for us right now, we're still in our prioritization group is 1A was health workers and long-term care facilities, and 1B1, which is where we are right now, is really above age 65. Although we do have, I think, at least I'm only aware of us doing this. We have in our 1B1 with the focus on equity, we have above the age of 50 who live in multi-generational households as a criteria. So you're either above 65 or you're above age 50 in multi-generational households. But again, because of what Nirav just said, that we haven't been tracking it in that way, but we've been tracking by age at this point, and then certainly race, ethnicity, because of obviously our concerns about equity.
All right, I failed to mention Stella last time. She had her, she's in first in line, but we're gonna have Stella, Sam, Jill, Stacy, Stephen Fowler, and Gabriella. So Stella.
Thanks, Chris. Estelle here with the Tennessean based in Nashville. So in Tennessee, there's sort of this like disconnect between the state and local, authorities in terms of vaccine distribution. So for example, our state already opened up eligibility statewide for 65 and older, but in metropolitan areas, we're seeing like Davidson County, where Nashville is, they're still vaccinating people 70 and older. And so I've got a lot of readers who are just confused whether they are eligible, because the state says they are, but Davidson County says they aren't. So, and in Tennessee, we do have this population-based distribution, which is based on the size of the population. So in theory, Davidson County shouldn't see such a backlog of vaccine distribution. So I was just wondering if, this is something that's happening across the nation, not just in Tennessee, and why it is happening, and whether you guys would have any solutions that you've seen in other states that might have worked to ease this problem. Thanks.
Yeah, I don't have much in the way of any solutions, but I have a sense of from where the problem emanates, Stella, and my sense is that, and I've had a discussion with another state health officer in another state where where a similar apparatus was emerging at the county level, and it has to do, and it makes total sense that it's happening in Davidson County relative to Montgomery or any other county in the area, because the demand and the concentration of people is much likely to be higher. So they move at a slightly slower rate than would be perhaps a rural county. Interestingly, to go back to an equity piece, an interesting finding in some of the data sets around vaccinations is that rural areas have outpaced on a rate basis urban areas. And so what happens is you don't want one part of the state moving through a population group 70 and over so quickly that they are then sitting idle, while another county is saying, whoa, Davidson County saying, we still have 1 million people to get through, and you start getting these disparities within states. So I think that's where the problem comes from, and thus why some counties have said, in our county, we're not dropping to 60 because we still have to finish everyone 70, and if we drop, we're going to have 70-year-olds who can't get appointments. That's where the problem comes from. The solution, as you can imagine, in counties like or states like Tennessee, where there's a radical divide between urban density and rurality, very difficult to keep going at the same rate for both.
Yeah, I'll weigh in a little bit. I mean, I think there's a little bit of, you just have to remember we have this supply and demand issue right now. And, I think because there was so much pressure, we moved pretty quickly to open the vaccine up to a wide range of groups, and there's just not enough vaccine for everybody. And I really think that's the best way to frame this, that people just have to realize that we're catching up with the demand. And, really, I know that it's not a very satisfactory answer for some people, but people are just going to have to be a little bit patient. We will get there, and I think we will get there in the next 4 weeks or so. But until then, I think you're going to see this playing out very differently in different places, but it boils down to the same basic issue.
Okay. So thank you very much. Dr. Nirav Shah just had to leave. So Sam, I'm sorry I wasn't able to work that question for him.
No problem. I can still ask it.
Sure, go ahead.
So Dr. Shah talked a little, hi, I'm Sam Metz from the AP in Nevada, by the way. Dr. Shah talked a little about maximizing channels to get shots into arms. I know that some state officials have said on the calls with the White House that they're worried about new federal programs like distribution to community health centers or the federally managed mass vaccination sites cutting into their state allocations. I was wondering if you could unpack the debate here. What do you think of these auxiliary channels, and what are the concerns from state health officials?
Yeah, thanks for that, Sam. And just really quickly for Stella, I went to Vanderbilt, so I'm a real big fan of the Tennessean, so I just wanted to throw that out there. Not that anything against anybody else on the call, and certainly I have a lot of respect for everyone else, but I just wanted to throw that out there. Sam, the real, let me give you what we're doing in Washington, and maybe just as a quick context that then I can answer the question. So we're really focusing on a multi-pronged, what we're calling multimodal strategy, which includes everything from healthcare and hospitals to pharmacies, community health centers, mass vaccination, tribal and local health jurisdictions. So we're looking at a whole gamut of all sorts of variety of different strategies. In the midst of all that, we have the federal government, which we're pleased to see this, and we have to give really incredible amount of credit to this administration for really focusing on increasing the capacity across the country for everything from vaccines to vaccinations. I mean, we have to really recognize what the federal government is trying to do and what this administration right off the bat said it was going to do, which was to support states and localities. The challenge behind the scenes is that some of the programs that may have been in the works prior or have now been new programs, that what we're doing is that states have now developed all these plans over the months because we were under a whole set of different assumptions and the way the strategies were. And now we're having some of those pivots that are happening at the federal level. What we have done is this multimodal plan to have our own way of vaccinating across the country within the states. And now you've got additional programs, which we welcome, to increase vaccines through channels like pharmacies or through community health centers. But if it's not coordinated and it doesn't have the input or the ability for even facts on the ground with states to be able to give information that helps with the intel on how to go about doing that successfully, or where to go about doing that successfully, or with whom to go about doing that successfully, then what happens is that then it becomes less effective and it starts to, it starts to impact the very state plans that have been put in place. And so what we are looking for is that coordination. And so that it's not just at the very end when, okay, here's the plan, and now pharmacies in your state are going to be getting something, or community health centers are going to be getting something. We want that input so we're not third-party observers, but we're actually equal partners in deciding how that's going to be done. We absolutely welcome additional channels, but we also want to make sure it doesn't impact the very plans that we have worked for months on end to put together. Does that make sense, Sam?
Yeah, let me just reinforce. I want to reinforce something that Umair said earlier. I mean, none of the states are opposed to vaccines going to other sources like federally qualified health centers or pharmacies. I mean, they're longstanding partners of the states. But I think the question is a question of timing, and I think that's part of what Umair's getting at. You know, we don't have very much vaccine right now. I feel that states have gotten a mandate from the federal government and from the public that they want speed right now. They want vaccine to go into arms as quickly as possible. If you want to do that, the most effective way to do that is through mass vaccination clinics. If that's not what we want, then that really needs to be articulated. And that may be one of the roles of the press, is to maybe call some of this into question and bring some balance to what the public's asking for, because it's, the problem with the mass vaccination clinics is, that's why we're starting to see the numbers now of who's getting vaccinated. It's white, generally affluent people. It's not people of color. And, we're concerned about that, but the current system isn't really allowing that. I think most states would love to work more with federally qualified health centers. That's a great way to bring diversity. Those are trusted entities, but it's a lot slower to go through a clinical facility like that and take the time for a patient to be able to talk to their doctor or provider a little bit about their hesitancy with the vaccine. So we're just going to have to decide where the balance of that stands.
Yeah, and just one last thing on that, Sam, is that, so for example, state of Washington, we were already working with pharmacies and community health centers. So those very pharmacies, community health centers that we were working with, those sectors are now the same sectors that are also being added with the federal system. So it's a coordination issue, and just wanting to have the coordination so that we are also involved in that process.
All right, so we have
Marcus,
less than 10 minutes. I want to
articulated.
I'm sorry?
Marcus, do you feel like that's not being articulated, the kind of balance between the speed mandate and other factors?
I don't think it's being articulated very effectively because it continues to be what's driving things. I mean, yeah, you know, we were talking earlier about Massachusetts. Massachusetts was really trying to balance that. And, you know, what happened is they started to look like they were underperforming because their numbers weren't as high as other states. So, you know, they got pushed to have to move more in that direction. So, you know, we talk about equity, but I don't think our actions are really kind of lining. And I'm not talking about the actions of state health departments. I mean, state health departments have been very, very concerned about equity, and I think would have probably rolled this out differently were it not for sort of the public demand and the push. So no, I don't think we're addressing that. I think we're going to, as we continue to see data, we're going to continue to see a lot of inequity. Hopefully that'll get fixed when there's a better supply of vaccine. And maybe that's just what we're going to have to do is get through this initial push. But no, it's very concerning that it's not an equitable process.
All right. And
Chris, one thing I would add just really quickly on the equity piece is that one other area of potential help that we would like to have is as best you can to articulate that when we're comparing race, ethnicity with vaccinations, that we're not just looking at it from the entire population of the state, because that's not that's not the denominator right now. The denominator is comparing it to who's in these priority groups that are right now eligible. And what that is a big set of confusion because, you know, some folks are like, well, this is what your percent is of that population in your state, but those aren't even the individuals that are potentially eligible. So we've got to really have a more nuanced narrative of that.
Hey,
All right.
Chris, I just wanted to follow up. There's a question requiring clarity from Tiffany in the chat for Dr.
Okay, I didn't see that.
About does Dr. I caught this too, and I want to make sure that's correct. But does Dr. Plesha believe vaccine dose supply will meet demand in the next 4 weeks, or are we just talking about a specific region?
I try to be optimistic. I mean, that would be great. I don't know. I mean, we are expecting to start to see numbers scale up. I mean, you know, the Johnson & Johnson vaccine will come onto the market. Granted, we're expecting fairly low numbers to begin with, but that'll pick up. Pfizer and Moderna are going to be picking up. So, you know, I do think in the next 4 to 6 weeks, we'll start to see some pretty significant improvements. You know, the other question is how long are we going to have this really robust demand for vaccine? I mean, you know, it's right now there are people who are highly motivated to get vaccinated, and then that's not particularly surprising. But what I feel like we don't have a great sense for is, you know, what percentage of the public out there is still hesitant about the vaccination? And, you know, unfortunately, when we get closer to those numbers, I mean, demand will fall off unless we start using some different kinds of strategies to reach those people and to kind of help them, you know, kind of make the decision. And I'm not talking about anti-vaxxers here. I'm talking about people who are hesitant, who, you know, are maybe interested in the vaccine, but they're a little scared of it, who maybe don't quite understand it. That takes a lot more time to really work with those people and those populations. I think we can bring a lot of those people over to where they're comfortable with getting vaccinated as well, but it's going to be a very, you're not going to do that at a mass vaccination clinic. People are going to need to come in and have a place where they can spend a little time talking to somebody.
Okay, so Dr. Shaw needs to leave in 4 minutes. We have 4 questions here. If you could keep, so yeah, Jill has a question, and if you could keep it fairly tight, and Dr. Shaw, keep your answer fairly tight, we're going to try to get a couple more questions in before everybody needs to go. So Jill?
Hi, Dr. Shaw. I'm Jill. I'm a producer and reporter for the Texas Standard in Austin, Texas. As you mentioned, alluded to earlier, we just went through that pretty, you know, it's overused, unprecedented storm last week. And I don't know, maybe you aren't the person that needs to answer this question. This is also open to our other guests, but do we have an idea of how far this might set us back? I mean, there are a lot of different, you know, figures and numbers that I've been reading about, and I don't know, I just don't feel like I'm getting a very good answer in regards to like, you know, the state's vaccination rate is already like pretty low, like a little above 5%. And people are still dealing with displacement and a lot of other issues caused by this natural disaster. So I'm wondering like how big the concern is that the vaccine rollout is going to see a major hiccup, or are you know, like, are y'all not too concerned about it? And also just like, what does this allude to other natural disasters? Because like, you know, California might, you know, they go through massive wildfires, it seems, every year. And that's another state that's, you know, also seeing very high number of cases. So just wanted your thoughts on that.
Yeah, Jill, thanks. And, you know, obviously I'm not gonna be able to, you know, articulate from a Texas perspective as much as I 2-3 months ago was able to. It's the first time in 20 years that I've been not a part of the emergency response some way since Tropical Storm Allison in Texas. So it's very different for me, or challenging to see things play out. What I would say is a couple of things. One is that we know that weather impact throughout this last week has actually had made impact to distribution and shipping and all sorts of other things. But it's also, we had winter storms up in Oregon and Washington as well, where there was also really a challenge of some of our mass vac sites had to be curtailed with their hours, their days of operation because of that. So I think there's a lot that's embedded in this. The reason you may not be getting the right answer that you're looking for is that probably it's very difficult to say right now, because we are still in the midst of that in Texas, right? And you know, I know that President Biden is here in Houston today, for example, and there is a lot of real concern about both what happened last week, but also the vaccination, and we're still in the midst of a pandemic. So I just think it's too early. But the one other thing I would say is that this just highlights the question that Marcus got, is highlights this answer, which is that yes, we have lots of plans, and yes, we have been doing planning. But if any of us think that from now till the end of this process of vaccinations that things are going to be absolutely perfect, we are completely off the mark here, because things will happen throughout that are going to be changes, pivots. They're going to be unanticipated issues that come in. I don't think any of us could have anticipated what was happening in Texas last week, and all of a sudden we were in it. And so this really underscores the most important piece, which is the ability to pivot and still be able to do what we need to do in order to get us out of this pandemic, which is what vaccines represent. So just kind of putting that all together, and happy to do some additional conversations offline if necessary.